The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
So a pleasant day to all. So I'm Harold Henison Chu. So I'm an internist endocrinologist. So today we'll be focusing our lecture on endocrinology. So for endocrinology, so just have to remember the more common conditions. So that includes, of course, diabetes, your thyroid disorders, and some of the more common general endocrinology conditions. Let's start with endocrinology. So of course, our first topic will be diabetes, in particular type 2. So a 50-year-old woman, overweight, presents to your clinic complaining of polyuria, nocturia, and weakness. She has a family history of hypertension and diabetes. On physical examination, she has acanthosis nigricans on the neck, and laboratory test shows fasting blood glucose of 140 and an HbA1c of 6.0%. So what is the most likely diagnosis? So if you are given an FBS and HbA1c on a single determination, ibig sabihin isang blood test lang. So the right way of saying it would be to consider diabetes mellitus type 2 because at least you need a repeat test to really establish the diagnosis, no? So usually we ask for a repeat test if it's just an isolated elevation of one of the diagnostic criteria. So what is the next best step in this patient? So the correct answer is to repeat FBS because it is the abnormal test. So your HbA1c of 6.0% is still within the impaired fasting glucose range. And the reliability, especially for an NGSP standardized assay, would be high. So yung fasting blood sugar yung i-recheck mo. Because in terms of stability, fasting blood sugar will change if the patient will restrict food intake over the last 3 to 4 days. But HbA1c remains stable because this reflects the average glycosylated hemoglobin over the last 3 to 4 months, no? Similar to your red blood cell lifespan, which is 90 to 120 days. So, what is the best initial therapy? So, kung ito yung findings mo, most likely medical nutrition therapy, exercise, and weight loss. But what is the best initial medical therapy? So, for now, it's still metformin, but later on, we'll show you the different clinical practice guidelines, which already outline that there are other first-line drugs and medications that we can give apart from metformin. So in detail, diabetes mellitus is a syndrome characterized by hyperglycemia, insulin resistance, and relative impairment in insulin secretion. So the symptoms of hyperglycemia include polyuria because of glucosuria. So you would whenever the sugar goes, the water will follow. And of course, with accompanying dehydration, you will result in increased thirst response in the form of polydipsia. And since you're losing calories, you get weight loss. So some patients would get fatigue, weakness, blurring of vision, pwedeng retinopathy ito. Frequent superficial infection, especially fungal infection. Slow healing of skin lesions after skin minor trauma. And for type 1 diabetes, it follows the same diagnostic criteria as type 2, which will show you later on, but the presence of autoantibodies is present in type 1. So for pathophysiology, you can see there are a lot of organ systems involved in diabetes. So that includes your pancreas primarily due to decreased insulin secretion resulting from the increased beta cell apoptosis with decrease in beta cell mass and increase in glucagon secretion. This is a counter-regulatory hormone that increases your blood sugar. Now, the gut is also involved in diabetes because of the impaired incretin effect. So recall your incretin effect is the potentiation of insulin secretion from an oral glucose load following a meal, no? So the liver is also involved in diabetes because this is the site of gluconeogenesis by increasing hepatic glucose output. And there's also a site of insulin resistance. Similarly, peripheral organs such as the muscle is involved in type 2 diabetes because of insulin resistance, meaning the sugars cannot go inside the muscle, even with binding of insulin to the insulin receptor in the muscle cells. The same could be said for adipocytes, where you have insulin resistance, increased circulating fatty acids, and hyperlipidemia. So these are just some of the medications that act on the different organ systems that improve glycemic control. And we will discuss these medications later on. So what are the risk factors to develop diabetes? So in the latest ADA 2023 guidelines, they say to consider testing in overweight or obese patients. So if you will base it on body mass index, it's actually 25, but for Asians, we use the WHO Asia Pacific criteria, which is just 23 for overweight. So those patients with these risk factors should have testing for diabetes, no? So family history of type 2 DM, physical inactivity, high-risk ethnicity, so that's Native American, Latino, Asian American, African American, Pacific Islander. Ito yung mga nasa Micronesia, your Aboriginal, indigenous population in Australia, New Zealand. And then hypertension with a BP of more than 140 over 90, this should be 90. HDL less than 35, triglycerides more than 250. Patients with PCOS, which is a manifestation of insulin resistance in the ovary. Severe obesity and acanthosis nigricans. This is manifestation of insulin resistance in the skin. History of cardiovascular disease. Now, patients who have impaired fasting glucose, impaired glucose tolerance, or an HbA1c of 5.7 to 6.4 should be screened every year. Patients with GDM should be screened at least every 3 years. And for individuals, we usually initiate screening at 35. This is not 45 anymore. This is 35. This 45 is based on Harrison's, but for ADA, it's already 35 in every 3 years. So individuals with HIV are considered high risk, so they must be screened for diabetes. Now, screening test utilizes fasting plasma glucose. This is the preferred test. You can also do a 75-gram OGTT, where you get the fasting first, followed by 75-gram OGTT, and then you check for the 2-hour glucose. So this is the oral glucose tolerance test and HbA1c. So unless there is a clear clinical diagnosis, so ibig sabihin patients have symptoms, the patients have unequivocally high HbA1c or fasting glucose, usually a second test is required for confirmation. So usually we request FBS and HbA1c together na. So this was what I was saying earlier. So in the latest American Diabetes Association 2023 guidelines, it already recommends screening of all individuals more than 35 every 3 years. But in the 21st edition of Harrison's, it's still 45. So this follows ADA 2020 and 2021. So it's not updated, no? So screening should be earlier if the patient is overweight, with one of the additional risk factors for DM we mentioned earlier, So the most common pattern of dyslipidemia is hypertriglyceridemia and a reduced HDL. So if you have abnormal screening tests, you have to repeat that abnormal test without delay before making a definitive diagnosis. And if there are two discordant test results, repeat the abnormal test. So yun yung nandun sa case ng patient natin earlier. Now, diagnostic criteria follows an HbA1c of more than or equal to 6.5%. A caveat is that the HbA1c should be measured using an assay standardized method. So it's an NGSP certified method. For fasting plasma glucose, it's more than or equal to 126 milligrams per deciliter or 7 millimoles per liter. Fasting is defined as no caloric intake for at least 8 hours. For the 2-hour plasma glucose, following 75-gram OGTT, this is more than or equal to 200 or 11.11 millimoles per liter. And lastly is random blood sugar. So random blood sugar of more than or equal to 200 milligrams per deciliter or 11.11 millimoles per liter with classic symptoms of hyperglycemia. So ito yung mga nabanggit na natin earlier, no? Polyuria, polydipsia, nocturia, polyphagia. So random is defined as without regard to the last meal. So how do we manage diabetes? So treatment comprises lifestyle, so that includes medical nutrition therapy, exercise, and weight loss. Most guidelines put metformin monotherapy at the onset of diagnosis for type 2, unless there are contraindications. No, usually we don't initiate metformin if the EGFR at diagnosis is less than 30, and we would decrease the dose if it's already less than 45. Any form of acidosis, because metformin has a rare side effect of lactic acidosis, unstable heart failure, liver disease, and severe hypoxemia. And you usually consider dual combination therapy if the A1C is more than or equal to 9%, and you consider injectable therapy such as basal insulin or your GLP-1 receptor agonist if the A1C is more than or equal to 10%. So, but again, it depends. So we don't readily just give treatments left or right. We still individualize according to the patient. So even nga minsan more than or equal to 9%, pero minsan it would be better to initiate insulin, especially if the patients are very symptomatic. So ito na-mention na natin, lifestyle change are the best initial therapy. And the preferred initial pharmacologic agent is metformin because it's accessible, it's quite cheap. And metformin blocks gluconeogenesis. And metformin is actually considered or can be used for the prevention of type 2 DM, especially those with impaired fasting glucose or in the pre-diabetic range. It's more beneficial for obese patients with BMI more than 35, those less than 60 years old, those who had a history of GDM or increasing A1C levels. But patients who are to undergo contrast imaging, such as MRI with GAD or CT scan with contrast, usually discontinue it 48 hours before, no? So just some clinical pearls on the different anti-diabetic agents. So remember, for weight gain, you have sulfonylureas, thiazolidinediones, and insulin. Now, those medications that actually promote weight loss include metformin, some modest weight loss. Then you have your SGLT2 inhibitor and your GLP-1 receptor agonist. So I think many people are familiar with your Ozempic, semaglutide. Agents that are weight neutral include DPP-4 inhibitors. Then we have incretins, are substances that we say that once they respond to an oral glucose load, the gut, K and L cells will secrete incretins to potentiate insulin secretion. So ito yung na-mention natin kanina. So incretins are primarily affected by GLP-1 receptor agonists and DPP-4 inhibitors. So GLP or glucagon-like peptide is actually a misnomer, no? Kasi nga glucagon raises glucose and free fatty acid levels because it's a counter-regulatory hormone. Whereas GLP actually decreases glucagon levels. So this is a table summarizing the different classes of drugs. So you have sulfonylureas, ito yung mga classic examples. And the non-sulfonylureas, which includes the glycides, which are the short-acting insulin secretagogues, and they increase insulin secretion. So since they increase insulin secretion, they lead to hypoglycemia and weight gain. Now, your biguanides include metformin. It's an insulin sensitizer. And adverse effects include weight loss, GI upset, lactic acidosis. Another class of insulin sensitizer is thiazolidine diones. Ito yung pioglitazone, no? Rosiglitazone. Kabaliktaran, they don't cause weight loss, but rather weight gain from fluid retention, some edema, heart failure. So, di siya pwede ibigay sa patients with heart failure. But since you have excess fluid, sometimes you get hemodilution, kaya nagkaka-anemia. Thiazolidine diones have also been shown to increase fractures and risk for bladder cancer. Now, alpha-glucosidase inhibitors inhibit intestinal absorption of sugars by blocking your enzymes that break down carbohydrates. So it leads to decreased absorption. So nakaka-weight loss din siya. But since it retains the sugars in your large intestine, it leads to some diarrhea and some flatulence. So ito yung common alpha-glucosidase inhibitors natin. Acarbose, miglitol, voglibose. The names sound very carbohydrate, no? Now, the ones we talk about for that act on incretin systems are DPP-4 inhibitors. Basically, DPP-4 promotes or increases the action of endogenous incretin by blocking the enzyme that breaks down incretin. So it prolongs endogenous action of GLP-1. So ito yung mga agents natin, mga leptins. So common adverse effects include headache, nasopharyngitis, hypersensitivity. Now, another form of drugs that act on your incretin system is GLP-1 receptor agonists. So these are injectables. You have the once daily and the once weekly. So ang weekly natin is dulaglutide, semaglutide. And these are analogs of GLP-1. So they're like agonists. And they lead to some skin irritation after injection and some GI symptoms like early satiety, reflux, and there's a rare side effect of C-cell hyperplasia in rats leading to medullary thyroid cancer. And these GLP-1 agonists are very effective in terms of weight loss by acting on the incretin system. And you have your sodium glucose transporter 2 inhibitors or SGLT2 inhibitors. Ito yung mga flozins. So they block the SGLT2 channel in the proximal convoluted tubule, leading to increased urinary excretion of glucose, leading to your glucosuria. So since mataas ang glucose sa urine, it can cause UTI kasi it's a substrate for, fungal candida and bacteria. Now, since you're losing glucose in water, it can lead to some form of dehydration. And rare side effects include risk of fractures for canagliflozin, bladder cancer for dapagliflozin, and some DKA. But these are rare side effects. Now, these are your non-insulin therapies. And you have your insulin therapies. So, madali lang hatiin si insulin, no? Rapid acting. So, these are injected mealtime. So, these are your analogs. Lispro, aspart, glulicin. Then you have your short acting. That's the human regular insulin or the R. And you have the intermediate acting insulin or the insulin N. That's isophane. And the basal insulin analogs, which are given once a day. So that's your Glargine, Detamir, and your Degludec. So these insulins can be distinguished by their onsets of action, the peak, and also the duration. So mapapansin mo yung mga basal, yung mga given once a day, it's just up to 24 hours to even more than 24 hours. So there's actually a new form of insulin that's coming out. It's the icodec. So it's given once weekly, but it hasn't been formally launched yet. So here you can see the pharmacokinetic profiles. So kapag ka rapid or regular, mas maaga yung peak and the duration of action is shorter compared to your intermediate acting and your basal or long acting. So ang difference lang nila is they have a peak for rapid and regular, and there's still a peak for your intermediate acting or NPH, kaya nakaka-hypoglycerin ito. But for the long acting, usually medyo peakless na sila. That's why the incidence of hypoglycemia is less for your basal insulin. So just some clinical pearls. So patients with diabetes may experience dawn phenomenon and Somogyi effect. So how do you distinguish the two? So see, dawn phenomenon is glucose levels rise in the early morning as growth hormones and cortisol secretion peak. So ito yung hyperglycemia from counter-regulatory hormones, no, in the morning. Kaya ito siya, yung blue. Now, Somogyi effect is a rebound phenomenon. Ibig sabihin, nag-hypoglycemia ka early in the morning, and then as a counter-regulatory response, there is increase in blood sugar. So, paano mo sila ma-distinguish? You get the blood sugar at midnight, 3 a.m. And si Somogyi, mababa. Si dawn phenomenon, hindi siya mababa. So, yun yung pang-distinguish natin between Somogyi effect and dawn phenomenon. So, how do you address the two? So, basically, dawn phenomenon, since hyperglycemia talaga siya, it's from counter-regulatory excess. I-move mo yung long-acting insulin mo from before evening to bedtime para ma-cover itong time na to. Whereas, for Somogyi effect, since nag-hypoglycemia ka dito, kailangan mong bawasan yung dose ng insulin mo sa gabi. All right? So, I hope that's clear. So, in a nutshell, how do we manage, monitor our patients comprehensively? So, all patients should have individualized glycemic goals in therapeutic plans. Patients are encouraged to have self-monitoring of blood glucose. So frequency is individualized. So syempre mas common or mas often blood sugar monitoring for patients on insulin. But patients on oral anti-diabetic agents can actually go away without monitoring of blood sugar, especially if they don't have hypoglycemia. HbA1c is usually done 2 to 4 times a year. So it's every 3 to 4 months for uncontrolled or change in medication. For patients who have controlled diabetes, usually every 6 months. Now, lifestyle management includes education and support, nutrition therapy, physical activity, psychosocial care, and including evaluation of depression, anxiety. There should also be detection and prevention and management of diabetes-related complications. So that includes your microvascular complication, retinopathy, neuropathy, and nephropathy, and also your macrovascular complications, no? Your coronary artery disease, peripheral artery disease, and stroke. So eye exam is usually annual biannual. Foot exam is 1 to 2 times per year by the provider, but it should be daily by the patient. So we encourage our patients, or at least teach them to check their feet daily. Kasi, di ba nga, a loss of sensation, di ba, from the peripheral neuropathy. So some patients won't have sensation kahit sobrang laki na ng wounds nila. So neuropathy examination should be done annually. And diabetic kidney disease, checking for your urine albumin to creatinine ratio should be done annually. And we aggressively treat and manage diabetes-associated conditions, such as hypertension, dyslipidemia, and of course, include your vaccinations. Now, just some particulars for the diabetes medications. Important to determine medications that have weight gain and hypoglycemia. So, among the different non-insulin therapies, only sulfonylureas have the risk to develop hypoglycemia. Whereas for weight, SGLT2 and GLP-1 receptor agonists usually lead to weight loss, whereas metformin just leads to neutral or modest loss. DPP-4 is neutral, and the three, insulin, sulfonylureas, and thiazolidinediones will lead to weight gain. Now, how do you choose your second-line therapy? So in the latest ADA and EASD guidelines, patients with established atherosclerotic cardiovascular disease or CKD, you should choose either GLP-1 receptor agonist or an SGLT2 inhibitor. So pwedeng isa dito. Now, those without established ASCVD, you have to check your patient's profile. Kung ayaw mo mag-hypoglycemia, pwedeng DPP-4, GLP-1, SGLT2, or even thiazolidinediones. Ayaw mo ng weight gain or gusto mo magka-weight loss, GLP-1 and SGLT2. But if cost is a major issue, medyo mura kasi is sulfonylurea and TZDs. Now, ito na yung exact algorithm from ADA 2023. So in the management of type 2 diabetes using glucose-lowering medications, so first you have to emphasize healthy lifestyle behaviors, including diabetes self-management education and support, as well as social determinants of health. Now, in the presence of ASCVD, like what we said earlier, can give an GLP-1 or an SGLT2. If patients have high risk for ASCVD, similar. Pag heart failure, SGLT2. CKD is still both of them, no? SGLT2 or GLP-1. Now, ito na dito na pumapasok yung iba pang factors. So, those with efficacy for weight loss, very high, would include GLP-1 receptor agonist and SGLT2 inhibitors. Ngayon, kung ang considerations mo is your cost, doon na papasok yung sulfonylurea and TZDs. Now, what are the adverse effects of insulin and oral anti-diabetic agents? So that includes your hypoglycemia. So hypoglycemia is characterized by Whipple's triad. So you have symptoms of hypoglycemia, a low plasma glucose concentration, and relief of symptoms after glucose level is raised. We'll go into more detail once we go to the hypoglycemia part of the lecture. And this is considered the most serious complication of diabetes therapy and management. Now, chronic complications of diabetes can be subdivided into macrovascular, microvascular, and others. So that includes cataract, sexual dysfunction, gastroparesis, and even wound infection. But these three are actually related to autonomic neuropathy. So just some clinical pearls. So non-proliferative retinopathy is found in many individuals who have DM for more than 20 years. So retinopathy, neuropathy, nephropathy are actually related to longer duration of diabetes. And the most effective therapy for diabetic retinopathy is prevention. Now, among the microvascular complications, diabetic nephropathy is the leading cause of CKD, ESRD, and those who would require dialysis later on. Most common form of neuropathy is the distal symmetric polyneuropathy, whereas part of autonomic neuropathy is erectile dysfunction and retrograde ejaculation, and these could be the earliest signs of actually diabetic neuropathy. So always remember to screen male patients with diabetes for erectile dysfunction. Kasi part of neuropathy na yun. So you'd be more aggressive in terms of treatment. Again, we discussed this earlier, most common lipid pattern and most common skin manifestations are cirrhosis and pruritus. Now we go to some questions. Which of the following patients most likely has diabetes mellitus? So the correct answer for this question is a 50-year-old male presenting with vomiting, decrease in sensorium with plasma glucose of 300 milligrams per deciliter. So bakit hindi A? Kasi it's CBG, no? It's not fasting blood glucose. CBG is not an approved method to diagnose DMs. Just be fasting blood glucose. Bakit hindi B? A 40-year-old male with 2-hour prandial glucose after 100 should be 75 grams OGTT. Bakit hindi C? Baka kasi tatanungin nyo, bakit hindi ano? So 6.5%. So usually we ask for a repeat test first or paired with FBS. And then D, because patient is in diabetic emergency. Most likely this is DKA. Second question, which of the following medications is considered to be first-line treatment for diabetes in addition to lifestyle modification? So ito dapat kuhanan nating lahat, no? Correct answer is metformin. So sulfonylurea, tanggal na sa choices. This is not first line for anything. Pwede ang SGLT2 if the question will read in a patient with ASCVD, heart failure, or CKD. No? DPP-4 is also not first line. Which of the following medications can cause weight gain? So this was emphasized many times earlier. So the correct answer is TZD. So tatlo lang naman may weight gain. Insulin, sulfonylurea, and TZD. So next question, based on the ESC 2019 guidelines among patients with diabetes and very high CV risk, target LDL is, so the correct answer is the lower the better, less than 55 milligrams per deciliter. So patients sa walang comorbids, usually 130. Patients with diabetes alone, without other risk factors, 100. Pagka merong isa pang risk factor apart from diabetes, let's say hypertension, proteinuria, it's less than 70. Pero kung meron kang ASCVD, ibig sabihin may history of MI, stroke, peripheral artery disease should be less than 55. All right. So next we go to metabolic syndrome, which is related to diabetes. So a 50-year-old Filipino male sought consult for pre-employment checkup. So patient has a weight of 95, height of 160. Blood pressure was 140/90, waist circumference 108 centimeters. Patient has triglyceride levels of 160 milligrams per deciliter, LDL of 35, and FBS of 110. So what is the most likely diagnosis? So you were given so much data. So to clump it up, pwede kasi siyang metabolic syndrome on the basis of impaired fasting glucose, hypertension, and also central obesity. What is this patient's BMI? So kahit hindi nyo tignan yung BMI, the waist circumference kasi is already here. So masasabi nyo na rin may central obesity yung patient. The BMI is 37.1. This is already obese, class 2 by Asia Pacific criteria. So the diagnosis of metabolic syndrome depends on which criteria you're using. So it could be from NEC-PATP3, 2001 criteria, or the more recent one is harmonizing definition plus pwedeng IDF criteria. So you have 5 criteria, and if you get 3 out of 5, it's already called metabolic syndrome. So you look at central obesity. So central obesity should be defined according to sex and also ethnicity. So for Asians, Chinese, and also South Central American, ito yung sinusunod natin. For males, it's more than or equal to 90 centimeters. For females, it's more than or equal to 80 centimeters. So for triglycerides, HDL, hypertension and fasting glucose, it's the same uh, definition for both criteria. So triglycerides, it's more than or equal to 150 or use of specific medication. For low HDL, it's less than 40 for males, less than 50 for females, or use of specific medications. For hypertension, it's a blood pressure of more than or equal to 130 systolic or greater than or equal to 85 diastolic or use of specific medication. And for fasting glucose, it doesn't have to be diabetes level, but just impaired fasting glucose of more than or equal to 100 or use of specific medication or previously diagnosed DM. Kaya sinama dito yung use of specific medication because patients with IFG might already be on metformin for diabetes prevention. So body mass index is classified according to category depending on criteria as well. So for international classification by WHO, these are cut-offs. And the cut-offs are lower for Asians. So ito siya, 18.5 to 22.9 is normal. 23 to 24.9 is overweight. Obese class 1 is already from 25 to 29.9. And obese class 2 is those more than or equal to 30. So anong meaning nito? What is the implication of this? It just means that Asians have a higher risk to develop cardiovascular disease and diabetes as well as metabolic syndrome at lower BMI cutoffs. So, mas high risk nga naman talaga tayo. Now, diabetic emergencies comprise two very important conditions that we will discuss. So that's your DKA and your HHS. So let's start with a case. A 22-year-old man with type 1 diabetes, poorly adherent to insulin, presents to the emergency room with nausea, vomiting, abdominal pain. On physical exam, he appears pale and diaphoretic, and his breath smells fruity. So he has a pulse of 110, blood pressure of 100/70, and a respiratory rate of 24. The laboratory test has a serum glucose of 450 milligrams per deciliter, high in iron gap metabolic acidosis, and positive serum ketones. So, dalawa lang differential. So, what is the most likely diagnosis? So, giveaway na you have hyperglycemia, HAGMA, and positive serum ketones. So, it's diabetic ketoacidosis. What is the next best step? So the correct answer is IV hydration and insulin administration. So treatment for diabetic emergencies is insulin. What is the pathophysiology of this condition? So patients with diabetic emergencies are usually due to relative or absolute insulin deficiency combined with counter-regulatory hormone excess from glucagon, catecholamines, and cortisol growth hormone. So this is adapted from Lupsa and Zucchi for the treatment of DKA and HHS. So basically, patients have either absolute or relative deficiency of insulin. So pag wala kang insulin, there will be increase in counter-regulatory hormones. If you have minimal or relative insulin deficiency, usually wala kang ketosis because ketone body synthesis won't be activated that much. Now, in the presence of absolute insulin deficiency, your adipose tissue will have increased lipolysis, leading to increased free fatty acids and glycerol to the liver. These are converted to ketone bodies and would lead to acidosis, decreasing your alkali reserve. So ito si ketoacidosis. Now, your triacylglycerol will lead to hyperlipidemia, and this would cause DKA. Now, in the presence of relative insulin deficiency, the muscle won't be able to act to absorb glucose. So there will be decreased glucose utilization. So glucose stays in the vasculature, leading to hyperglycemia. Now, amino acids will increase because there is increased amino acid protein breakdown in the muscle due to the absence of insulin. These will go to the liver and will increase your gluconeogenesis by converting amino acids into glucose. Then the liver will also undergo increased glycogenolysis kasi nga, di ba, it stores glycogen. So, since walang insulin, it will break down glycogen to glucose. Now, wala kang insulin, so also decrease glucose utilization, also leading to hyperglycemia. Hyperglycemia leads to glucosuria and osmotic diuresis, leading to dehydration. If you have very profound dehydration in the setting of hyperglycemia plus relative insulin deficiency, it leads to hyperosmolality. So that leads to your HHS. Now, again, it results from relative or absolute insulin deficiency combined with counter-regulatory hormone excess. And for DKA, there is a triad: hyperglycemia, metabolic acidosis or high anion gap metabolic acidosis, and ketosis or positive serum ketones or positive urine ketones. How would you distinguish? Again, in terms of insulin deficiency, mas marked ang deficiency ng DKA. Parehas sila may hyperglycemia, but mas mataas ang hyperglycemia ng HHS. Patients with DKA have HAGMA. So pH is most likely less than 7.3 plus ketosis. For HHS, more profound dehydration. So it leads to hyperosmolarity and there's no acidosis. So for treatment, medyo similar lang. Parehas kailangan insulin. Parehas kailangan IV fluids. But since more profound ang dehydration sa HHS, you need more aggressive IV fluids. Now, mortality rate, mas mataas sa HHS. It's because patients with HHS usually have more severe comorbidities, are usually older, and at the same time have more chronic hyperglycemia compared to DKA. Mas acute kasi ang DKA. So this is another useful table adapted from Inzucci, showing you how to distinguish mild, moderate, severe DKA from HHS based on plasma glucose, pH, bicarbonate, ketones, osmolality, anion gap, and mental status. But basically, for mild DKA, alert, and moderate is alert/drowsy. Patients with severe DKA usually stuporous or in coma. And for HHS, yun na, no? Pangit na talaga yung sensorium. So how do you calculate your effective serum osmolality? Just add your serum glucose 2 multiplied by serum sodium plus glucose in milligrams per deciliter divided by 18. So you don't use BUN in the calculation of effective osmolality because it is a permeable solute. So you don't use BUN. An ion gap is calculated by deducting the sum of chloride and bicarbonate from sodium. High ion gap means it's higher than 12. So for patients presenting with DKA and HHS, it is important to identify the 5 I's of for precipitating factors. So what are the 5 I's? It includes infection, ischemia, infarction, intoxication, and ignorance, no? Or poor control. I just say poor adherence. So before you start insulin, you have to rule out hypokalemia first, because if you initiate insulin therapy, that would upregulate your sodium-potassium ATPase pump, which pumps potassium intracellular to the cell. So, lalong mag-exacerbate si hypokalemia. The major non-metabolic complication of DKA therapy is cerebral edema. Bakit nagkaka-cerebral edema? Because if there is sudden reduction of blood sugar, it will lead to intracellular shift of fluid into the cell. So, pwede ka magkaroon ng cerebral edema. So, medyo maingat tayo sa pagbaba ng sugars for patients with DKA in HHS. So later on, I'll show you how you would decrease the sugars. So for treatment, both would require IV fluid replacement. Usually we start with normal saline. You start with 2 to 3 liters of plain NSS over 1 to 3 hours. And once your sugar reaches 250 milligrams per deciliter, you add D5 containing. Kasi nga ayaw natin masyado bumagsak yung sugar to prevent cerebral edema and hypoglycemia. Now, insulin therapy is given at a dose of 0.1 units per kilogram. So, ibig sabihin, if your patient is 60 kilos, you give 6 units per bolus and then 6 units per hour. So potassium replacement is essential because, as we said earlier, treatment with insulin, IV insulin, would cause exacerbation of hypokalemia due to intracellular shifting. Bicarbonate is usually not given except for very, very severe acidosis with a pH of less than 7. And like what I said, seek underlying factors or precipitating factors. So, cornerstone, 4 lang naman. IV fluids, insulin, potassium, and bicarbonate. So, for IV fluids, determine hydration status. If severe hypovolemia, give NSS. Cardiogenic shock, walang question, vasopressors and hydration. Mild dehydration, evaluate sodium. If it's high or normal, pwedeng 0.45 NaCl. If it's low, you give plain NSS. Now, if the serum glucose reaches 200 for DKA and 300 for HHS, you change your fluid to D5 containing 0.45 solution para ma-prevent ang cerebral edema and also rapid reduction of sugar, which might lead to hypoglycemia. Now, bicarbonate is only given if pH is less than 6.9. So insulin is usually given IV route. So give a bolus of 0.1 unit per kilogram body weight. So kung 60 nga, 6 units IV bolus. So remember, it's IV, not subcutaneous because of erratic absorption and slower onset of action. So si IV insulin, mabilis, no? Mabilis din ma-off. Now, continuous infusion is usually given 0.1 unit per kilogram per hour. So kung 60 nga yung patient, 6 units per hour yung binibigay. Now, you adjust your insulin depending on which protocol you use. No? Usually, you can use modified yield protocol. You can use Inzuchi protocol. So, it depends. Si Portland protocol is only used for patients with undergoing coronary artery bypass. So, Portland protocol is not for diabetic ketoacidosis and HHS. Again, remember, when serum glucose is already 200, you decrease your insulin infusion and you start D5 containing fluids. For HHS, the cutoff is 300. Now, when do you start overlap of IV and subcutaneous? So you allow a 2-hour window. Like what we said earlier, mabagal ang onset of action of subcutaneous regimens. So we usually start them 2 hours before discontinuing IV drip. Then for potassium, you have to check if it's less than 3.3. Usually you stop insulin and correct potassium first. If it's more than 5.2, do not give potassium, but check your serum potassium every 2 hours. And if your potassium is 3.3 to 5.2, you can supplement your IV fluid with potassium. So usually ako, the personal practice namin is to supplement patients with potassium, except yung mga CKD5 patients, no, na expected mo hyperkalemic talaga sila. But usually, if the creatinine function naman is normal, the patient would be able to excrete naman the potassium you're giving in the IV fluid para hindi kayo mahirapan. So I usually give IV fluids together with the insulin drip. So very important is to monitor your electrolytes, your BUN, your pH, your creatinine, and your glucose every 2 to 4 hours. Ano bang rationale behind this? Why do you need to monitor very closely? It's because patients for DKA, you want to check if the patient is already improving. Ibig sabihin, nag-i-improve yung pH, nag-i-improve yung anion gap, nag-i-improve yung sugar, hindi wala kang AKI, wala kang acute kidney injury, and your glucose is actually decreasing. So, actually for laboratories, in practice, usually we check every 4 hours para hindi masyadong toxic. But for sugar, we usually check every hour kasi that would help us adjust our insulin drip every hour. So, complication of diabetes treatment, DKA HHS treatment is hypoglycemia. So, hypoglycemia could be caused by your insulin as well as insulin secretagogues such as sulfonylureas, but it could also be due to endogenous hyperinsulinemia. So, example dyan is insulinoma. But these conditions are rare. So, remember, your arterial glucose supplies the brain. It also supplies, the levels are also detected by the pancreas. So, pag bumagsak ang sugar, ang first response ng pancreas is stop insulin secretion. Kasi nga, ayaw na natin more bumagsak pa siya. Pag bumaba si insulin, second response, increase si glucagon. Kasi glucagon has to act on the liver to increase glucose production to prevent hypoglycemia. Now, the other lines of defense include counter-regulatory hormones, no? Epinephrine, growth hormone, and cortisol. So, huwag niya masyado isipin tong figure, but the more important table is this one, which is the physiologic responses to decreasing plasma glucose concentration. So, the first response against, or first defense against hypoglycemia is decrease in insulin. So, this is called the primary glucose regulatory factor. So, tandaan nyo lang dito yung glycemic threshold. It's 80 to 85. Now, glucagon or increasing glucagon, which is the second defense, but is the first counter-regulatory factor, occurs at a sugar level of 65 to 70. So, epinephrine, growth hormone, cortisol, madali nang tandaan kasi lahat sila 65 to 70 cut off. So, epinephrine is third defense, but is only critical when glucagon is deficient. Cortisol and growth hormone are involved in the defense, but they are not critical. So when do you get symptoms of hypoglycemia? So kailan siya na-recognize? Usually when sugar levels are down to 50 to 55. So this is when prompt behavioral defense, such as food ingestion, takes place. Now, when do you get decreased cognition? Pag less than 50 na. Pag ito na, compromises behavioral defense na, ito na yung mga patients na nagsi-seizures na nako-comatose na sila. So please remember the cutoffs and the role of each of these hormones. Ito lang yung kailangan yung tandaan sa hypoglycemia. All right? So now we're done with one of the most important conditions in endocrinology and also comprises bulk of your exam. Now we go to the second most common condition. So that would include hyperthyroidism, hypothyroidism. So let's start with hyperthyroidism. So a 20-year-old woman presents to your clinic with palpitations, tremors, and unintentional weight loss. On physical exam, she is tachycardic at 110 beats per minute. There is noted mild proptosis bilaterally and diffusely enlarged thyroid gland. What is the most likely diagnosis? So the correct answer is hyperthyroidism from Graves' disease. Why Graves' disease? Because the patient presented with eye symptoms and a diffusely enlarged thyroid gland. So what is the initial test of choice? Actually, the most sensitive test to detect thyroid dysfunction is thyroid stimulating hormone, or TSH. So next question, when to repeat thyroid function test after starting treatment? After 4 to 6 weeks. What is the pathophysiology of the condition? Graves' disease is an autoimmune condition that results in the excess synthesis and release of thyroid hormones because of the thyroid stimulating immunoglobulin. All right. And what is the most common sign of thyrotoxicosis? The correct answer to this is tachycardia. So some epidemiology, thyrotoxicosis is a state of thyroid hormone excess and is not synonymous with hyperthyroidism. So ibig sabihin, thyrotoxicosis could be due to any form of increase in thyroid hormones. Kahit yung mga patients na nag-overdose ng levothyroxine, that's already considered thyrotoxicosis. But hyperthyroidism only pertains to excess thyroid function. Ibig sabihin, endogenous thyroid excess yun. Yung katawan mismo yung gumagawa ng excess thyroid hormone. So it doesn't include excess levothyroxine ingestion. So hyperthyroidism is caused by Graves' disease, accounting for around 60 to 80% of cases, and it's more common in women. So actually, any form of thyroid condition naman, even hypothyroidism is more common in women. So this table neatly summarizes the different causes of thyrotoxicosis. It's subdivided into primary hyperthyroidism, meaning that the condition is in the thyroid. So, kasama ang Graves' disease, toxic multinodular goiter, toxic adenoma, functioning thyroid carcinoma metastasis, activating mutation of the TSH receptor, your McCune-Albright syndrome, struma ovary, and drug excess, iodine excess, or the Yod-Basedow phenomenon. There are also cases of thyrotoxicosis without hyperthyroidism. That's what we said earlier. Any form of thyroid hormone excess is thyrotoxicosis, but not hyperthyroidism. So that includes thyroiditis from increased release of preformed hormones due to destruction of thyroid follicular cells. Other causes of thyroid destruction, such as amiodarone-induced thyrotoxicosis, radiation-induced, or even infarction of a thyroid adenoma. And ito yung sinasabi natin earlier, ingestion of excess thyroid hormones as a condition called thyrotoxicosis factitia, or ingestion of thyroid tissue. Now, there are other causes of hyperthyroidism which are secondary, meaning the disease is not in the thyroid but elsewhere. So that includes a TSH-secreting pituitary adenoma, and this TSH secreted by the adenoma stimulates your thyroid gland. Thyroid hormone resistant syndromes can also present as secondary hyperthyroidism. Patients with chorionic gonadotropin secreting tumors, H-molds, and choriocarcinoma can actually cause hyperthyroidism because HCG stimulates the thyroid, as well as gestational thyrotoxicosis. So similarly, the reason for this is also stimulation of the thyroid by HCG, your human chorionic gonadotropin. So what are the clinical and laboratory features of Graves' disease? So Graves' disease presents with a diffusely enlarged thyroid gland, usually 2 to 3 times of the normal size. You may hear thrills and bruit on auscultation because of increased vasculature and vascular flow. And classic for Graves' disease, masasabi mong Graves' disease siya from Graves' ophthalmopathy, proptosis, lid retraction, and periorbital edema, which are hallmark findings. And thyroid dermopathy is also a specific sign of Graves' disease. This is usually presents usually as non-inflamed orange skin or poddy orange plaques. So since you have high total and unbound thyroid hormones, it exerts negative feedback on the pituitary gland, causing low TSH. So thyroid function tests and clinical manifestations should be reviewed every 4 to 6 weeks after starting treatment. And the dose of medications or your anti-thyroid drugs are usually titrated based on unbound T4 levels. Now, cytokines play a major role in thyroid-associated ophthalmopathy by causing muscle swelling. Kaya nga, pag masyado ng long-standing yung ophthalmopathy mo, usually it becomes irreversible. So increased orbital fat is an additional cause of retrobulbar tissue expansion. Now, how do you recognize hyperthyroidism or thyrotoxicosis based on symptoms and signs? So, very useful table from Harrison's. So, this table hasn't changed over the last 10 years. So, in descending order of frequency, you have symptoms of hyperactivity, irritability, dysphoria, heat intolerance, sweating, palpitations, fatigue and weakness, weight loss despite increased appetite, diarrhea, polyuria, oligomenorrhea, and loss of libido. So, very classic symptoms of hyperthyroidism that you can elicit from your patients. Now, for signs, the most common sign is tachycardia. For elderly patients, it's atrial fibrillation. Patients get tremors, a goiter, warm, moist skin, muscle weakness, proximal myopathy, lid retraction or lid lag, and even gynecomastia. Now, signs of ophthalmopathy and dermopathy are specific for Graves' disease. So if you see features of ophthalmopathy and dermopathy, the correct way of labeling your hyperthyroidism would be to say Graves' disease. But kung wala kasi to, pwede siyang toxic multinodular goiter or toxic adenoma. But Graves' disease can also be determined from a positive thyroid receptor antibody test, positive or high levels of TRAB antibody. So these are just some basic science correlates. Graves' disease can cause thyrotoxic hypokalemic periodic paralysis. And hypokalemia causes hyperpolarization of muscle. So it impairs the capacity to depolarize and contract. Review of your physiology. So thyrotoxic periodic paralysis usually occurs around midnight. So actually, I've seen this in most of our patients, usually patients with Graves' disease and smokers, male. Most common manifestation, cardiovascular manifestation, is sinus tachycardia. So Graves' disease in terms of diagnosis, it's actually straightforward. No, kasi patients will present with elevated FT4, FT3, suppressed TSH, and then they will have diffuse goiter. They will have ophthalmopathy and usually have other autoimmune disorders. So it's actually easy to exclude thyrotoxicosis because if the TSH is normal and FT4, FT3 are normal, matatanggal mo na siya. In fact, a normal TSH excludes Graves' disease as a cause of diffuse toxic goiter. Kasi nga, TSH or thyroid stimulating hormone is a very sensitive assay for thyroid dysfunction. So this is just a very helpful algorithm, also derived from Harrison's. This hasn't changed over the past 10 years as well. So the basis for this is physiology. Remember, hypothalamus secretes TSH releasing hormone. TRH acts on the pituitary gland to secrete TSH or thyroid stimulating hormone. TSH acts on the thyroid gland to produce T4 more than T3. So mas marami ang T4 galing sa thyroid gland. And in peripheral tissues, T4 is converted peripherally to T3. And T4 and T3 act on the hypothalamus to suppress TRH. And they act on the pituitary to suppress TSH from negative feedback. So pag mataas ang FT4 and FT3 mo, they will act on pituitary to suppress TSH. Yun yung hyper. Ngayon, kapag hypo ka naman, baliktad. Mababa ang T4 and T3 mo sa katawan. So the pituitary gland will not detect T4 and T3. So it will release it from negative feedback, causing a rise in TSH. So later on, I'll show you in the part of hypothyroidism. So how do we approach patients with thyroid or suspicion of hyperthyroidism? So you measure TSH and unbound T4. Unbound T4 is also called free T4. So if mataas ang free T4, bagsak ang TSH, this is called primary thyrotoxicosis. If you have features of Graves' disease, meaning you have ophthalmopathy and dermopathy, yes, Graves' disease. If wala, it could be multinodular toxic goiter or adenoma. So for this step, you check the radionuclide uptake. So if the radionuclide uptake is low, ibig sabihin hindi hyperfunctioning ang thyroid. It could be due to destructive thyroiditis or iodine excess. If it has a high radionuclide uptake, then you have to rule out other causes that stimulates the thyroid. So that includes chorionic gonadotropin secreting tumors, that's the H-mole, choriocarcinoma. Now, if your TSH is suppressed but the FT4 is normal, you request for unbound T3 or free T3. If it's high, it's T3 toxicosis. That's the reason why it's best to measure FT for FT3 and TSH all together in one blood sampling. Now, if it's normal, your free T3 is normal, it could just be due to subclinical hyperthyroidism. Ibig sabihin, normal ang hormones, TSH lang ang suppressed. Now, if both TSH and free T4 are elevated, then it means that it's secondary hyperthyroidism. Hindi sa thyroid nang galing kasi hindi suppress ang TSH. So this could be due to TSH secreting adenoma or thyroid hormone resistance. If both are normal, no further testing is required because of the high sensitivity of TSH, which could exclude thyroid dysfunction. So please remember the normal values for FT3, FT4, and TSH because in the past exams, the examinees were given values of FT4, FT3, and there were no reference values to help you interpret whether it's high or low. So please familiarize. How do we treat hyperthyroidism? You can give antithyroid drugs in the form of PTU for pregnant patients in the first trimester, methimazole for all other patients and in the second and third trimester. So ATDs reduce thyroid hormone synthesis by blocking your thyroid peroxidase enzyme. But antithyroid drugs only have a success rate of inducing clinical remission of hyperthyroidism by around 20 to 30%. The higher chance of cure is actually radioactive iodine ablation or RAI, which has around success rate of 90 to 95%. So this is RAI is the new definitive therapy. So RAI ablates the thyroid by reducing the amount of thyroid tissue due to radiation-induced follicular destruction, but it's best avoided in patients with moderate to severe ophthalmopathy due to exacerbation of the eye symptoms. And it's contraindicated in patients who are pregnant, planning pregnancy, or are breastfeeding because of its transfer to the placenta and also through breast milk. Propranolol, a non-specific beta blocker, is given to control adrenergic symptoms. And steroids in the form of methylprednisolone pulse therapy are given for very severe ophthalmopathy to decrease inflammation. And surgery or total thyroidectomy is indicated for very large goiters with nodules, no? Because very large goiters sometimes do not respond very well to radioactive iodine because of its large size. So how do you prepare for RAI? Usually we discontinue PTU for around 7 to 14 days and methimazole 3 to 5 days before RAI so we can achieve optimum iodine uptake in the thyroid gland. And patients are advised to avoid prolonged contact with children and pregnant women for around 5 to 7 days post-RAI. So we usually ask them to isolate for 1 week on their own. And it's the most serious manifestation of Graves' ophthalmopathy is optic nerve compression. So this would lead to permanent loss of vision if left untreated. So usually if there's already suspicion of optic nerve compression, we usually refer to ophthalmologists for co-management and treatment. Now let's go to the most severe manifestation of hyperthyroidism, which is thyroid storm. So for this case, a 40-year-old woman with Graves' disease presents to the emergency room with fever, vomiting, palpitations, and jaundice. She has been receiving treatment for pneumonia and has been poorly adherent to methimazole. On physical exam, patient is febrile and tachycardic at 120 beats per minute. So what is the most likely diagnosis? So this is Graves' disease and thyroid storm with a Birch-Wartowski score of 65. What is the anti-thyroid drug of choice? It's PTU, propylthiouracil. What treatment will reduce adrenergic manifestations and peripheral conversion of T4 to T3? So the correct answer is propranolol. And what is the treatment that blocks thyroid hormone synthesis via Wolff-Chaikoff effect? It's stable iodine. So thyroid storm is a clinical diagnosis. It's scored upon admission. Hindi siya ini-score pag stable na yung patient. It's scored during diagnosis, during admission. So you look at several criteria at thermoregulatory dysfunction, central nervous system manifestations and effects, GI hepatic dysfunction, tachycardia, heart failure, atrial fibrillation, and precipitant history. So each of the criteria will have corresponding points depending on the score satisfied by the patient, and you get the total score. So patients with score of more than 45 is highly suggestive of storm. Those who have a score of 25 to 45, it's impending storm, and less than 25 is less likelihood of having a storm. So thyroid storm is a rare, life-threatening exacerbation of untreated hyperthyroidism. It's usually precipitated by acute illness such as 5-eyes in diabetic emergencies. So stroke, MI, infection, trauma, surgery, among others. So accompanying features are usually fever, central nervous system in the form of delirium, seizures, coma, vomiting, diarrhea, jaundice. So ito yung sinabi natin kanina, Birch-Wartowski score, less than 25, unlikely to be storm. 25 to 44 is impending storm. And more than 45 is high likelihood of storm. So question, which drug should not be used in patients with thyroid storm? So the correct answer for this question is letter B, amiodarone. So amiodarone is an iodine-containing antiarrhythmic agent. So usually don't give this to patients with hyperthyroidism and storm. So how do we treat thyroid storm? So these are the three important goals. So you have to stop the production of thyroid hormones. So you either give PTU per orem or per rectum. You can give metimazole. So ito yung dalawang ATDs natin, but the preferred one is PTU. So we'll explain later on. And then sometimes we give steroids, no, because patients might be having relative adrenal insufficiency. Now, we also need to block peripheral effects of hormones. So that's propranolol. And to inhibit hormone release, no, ibig sabihin, kasi di ba yung thyroid gland mo, may mga stored hormones na yan. So you want to prevent its release. So we give saturated solution of potassium iodide or SSKI 1 hour after the first dose of PTU. And pwede rin sodium iodide. So this is a very nice table from the American Thyroid Association guidelines showing you that PTU is the first-line drug to block hormone synthesis. It has the advantage of blocking peripheral conversion of T4 to T3, and it also blocks new hormone synthesis. So the loading dose is 500 to 1,000 milligrams, and then 250 every 4 hours. This is, metimazole can also be given, no, actually, kung walang PTU. It's usually given 60 to 80 milligrams per day. Kaya lang disadvantage, wala siyang, it doesn't block peripheral conversion. Propranolol, our beta blocker of choice, is given at 60 to 80 milligrams every 4 hours, but it has to be given with caution in patients with heart failure due to the possibility of congestion. So propranolol blocks T4 to T3 conversion, and an alternate drug is esmolol IV. Kaya lang hindi natin siya commonly nagagamit. Now, iodine in the form of saturated solution of potassium iodide is given 5 drops every 6 hours. So this blocks new hormone synthesis and also blocks thyroid hormone release. So caveat, do not start until 1 hour after antithyroid drugs kasi you don't want that iodine to be incorporated to more synthesis. Kailangan i-block mo na yung synthesis. So hydrocortisone is given as a 300 milligram IV load and then 100 milligrams every 8 hours. So it also may block T4 to T3 conversion, and at the same time, it's a good prophylaxis against relative adrenal insufficiency. So this is just a diagram showing you the different points of action of the different drugs that we're giving for thyroid hyperthyroidism at the same time for thyroid storm. So remember your physiology. Iodine is transported by the sodium iodide symporter into the thyroid cell. And this iodide is oxidized by peroxidase and organified into tyrosine residues of thyroglobulin to produce MIT-DIT. MIT-DIT will couple or undergo coupling to produce T3 and T4, and proteolysis of thyroglobulin to release T4 and T3 to the blood, where they will go to the peripheral tissues and bind to the thyroid hormone receptors, causing peripheral action. So thiocyanate and perchlorate actually block sodium iodide symporter, but these are not readily available and has many adverse effects, so they're not commonly used in the treatment of hyperthyroidism. Now, your iodides and thionamides block the organification step in the thyroid gland. So ito na yung metimazole PTU. So it blocks organification. So iodine does not get incorporated to thyroglobulin. Now, your iodides or your SSKI blocks proteolysis or the release of thyroid hormones from the thyroid. And the conversion of T4 to T3 in the periphery is blocked by beta blockers, steroids, radiocontrast media, and also amiodarone. But the ones that we use in treatment of thyroid storm only include beta blockers and corticosteroids. Some clinical pearls, stable iodide is given to block thyroid hormone release via the Wolff-Chaikoff effect. Wolff-Chaikoff effect allows anti-thyroid drug to prevent excess iodine from being incorporated into the new hormones. That's why you have to give ATDs first to stop organification bago ka magbigay ng iodide. Para yung iodide mo won't be incorporated to synthesis but would instead block hormone release. Now, PTU, again, is favored over metimazole because it decreases the peripheral conversion of T4 to T3. So, important to kasi T3 is more potent than T4 when it acts on thyroid cells, thyroid receptors in the periphery. All right, so we've covered hyperthyroidism. Now let's go to the opposite naman of its manifestation, and that's hypothyroidism. So let's start with a case of a 32-year-old woman who complains of fatigue, weakness, weight gain, menstrual abnormality over the past 3 months. On physical examination, the patient has puffy eyelids, dry skin, enlarged thyroid, bradycardia, and delayed tendon reflex relaxation. So what is the most likely diagnosis? This is hypothyroidism. What is the best screening test? So now we discussed this earlier for hyperthyroidism. So similar to hyperthyroidism, the best screening test for thyroid dysfunction is TSH. So it's the most sensitive test to screen for thyroid dysfunction. So what is the most appropriate treatment? Of course, hypothyroidism, kulang ang thyroid hormone, so you give hormone replacement. So in the form of levothyroxine. What is the most common cause of this condition worldwide? So this is iodine deficiency, but actually we rarely see it nowadays, especially in the Philippines. So in iodine sufficient regions, what is the most common cause? It's actually autoimmune or Hashimoto's thyroiditis, as well as your iatrogenic treatment of hyperthyroidism. Pwede din naman post-surgical for patients who have thyroid cancer. Some clinical features: iodine deficiency remains a common cause of hypothyroidism worldwide. And in areas of iodine sufficiency, we have autoimmune causes such as Hashimoto's or due to treatment of hyperthyroidism. So the goiter of hypothyroidism is usually irregular and firm in consistency as compared to Graves' disease where the goiter is diffuse. Typical features include puffy face, edematous eyelids, and non-pitting pertibial edema because of fluid retention due to slowed metabolism and turnover of fluids. Thinning of the 1/3 of the eyebrows is sometimes seen. So, just a question. The following are signs of hypothyroidism except. So if you were looking at the table for hyperthyroidism a while ago, you'd be able to note the answer. So the correct answer is letter C, moist skin. So hypothyroidism is characterized by these signs and symptoms. So again, this is a classic table in Harrison's in descending order of frequency. In terms of symptoms, you have tiredness, weakness, dry skin, feeling cold, cold intolerance, hair loss, difficulty concentrating and poor memory, constipation, weight gain despite poor appetite, dyspnea, hoarse voice, menorrhagia, and later on, patients will have oligomenorrhea and amenorrhea, paresthesia due to carpal tunnel or thickening of the median nerve, carpal tunnel area, compressing the median nerve, and impaired hearing. So these signs are actually quite the reverse of hyperthyroidism, and they're very easy to recognize in your patients who are seeking consult. Now, for the signs, patients usually have dry, coarse skin, cold peripheral extremities. They have puffy face, hands, and feet due to myxedema, diffuse alopecia, bradycardia, which is the reverse of tachycardia, peripheral edema, delayed tendon reflex relaxation, carpal tunnel syndrome, and serous cavity effusions in the form of pericardial effusion, pleural effusion, or even ascites. So it's easy to remember the symptoms and signs of hypothyroidism because thyroid hormones are in charge of the overall body's metabolism. So if you have a decrease in thyroid hormones, that would lead to slowing down of your body's metabolism. So ito yung mga manifestations niya. So it's easy to remember. Now, diagnostic algorithm is to first measure TSH. So since there is a low level of thyroid hormones in the body, you will release the pituitary gland from negative feedback, leading to a rise of TSH. So if it's elevated, you measure free T4, but usually we do it simultaneously para isang blood extraction. If the free T4 is low, it's primary hypothyroidism, meaning that the problem is coming from the thyroid. So the next step is to check antibody levels because we know that autoimmune hypothyroidism is the most common cause in iodine-sufficient regions. If it's antibody negative, probably could be iodine deficiency or other causes of hypothyroidism. Let's say, yun nga, mga naoperahan, post-total thyroidectomy or post-RAI. And if the free T4 is normal, it's called mild hypothyroidism. Still, you check for antibody because autoimmune hypothyroidism can sometimes have normal FT4, especially in early stages where the thyroid is able to compensate. If autoantibody is positive, your anti-thyroid peroxidase antibody is positive, or the patient is symptomatic, you start treatment. If the patient is asymptomatic or antibody negative, you just do annual follow-up. So, kanina, balikan natin, patients with autoimmune hypothyroidism, automatic you have to treat with T4 replacement. Now, if the patient's TSH is normal and you suspect pituitary disease, if it's yes, again, measure T4. Pag parehas mababa or so if parehas mababa, you have to rule out drug effects, sick thyroid syndrome, and also at the same time evaluate anterior pituitary function if you're suspecting pituitary disease. So you have to evaluate growth hormone, cortisol, your gonadotropin axis, FSH, LH, as well as prolactin. Now, if normal lahat, no further testing is required. So this is just a summary of the different tests. High TSH, normal FT4, mild hypothyroidism or subclinical hypothyroidism. High TSH, low FT4 is primary hypothyroidism. Pag positive antibody, it's autoimmune hypothyroidism. If normal TSH and low FT4, pwedeng drug effect, sick thyroid syndrome, or pituitary disease. Sick thyroid syndrome simply refers to a condition outside the thyroid that is disrupting thyroid function. So non-thyroidal illness is another term for that. So logical approach, if to thyroid disease, check the TSH is the most useful screening test if it's suppressed, normal, or elevated. A normal TSH excludes thyroid abnormality. So ibig sabihin hindi siya hypo, hindi siya primary hypo, hindi siya primary hyper. And then the most common cause of elevated TSH remains to be hypothyroidism. We've discussed the laboratory features of hypothyroidism. Again, increased TSH and decreased unbound T4. And once clinical or subclinical hypothyroidism is confirmed, the etiology is usually established by checking anti-TPO and anti-TG. So anti-TPO stands for anti-thyroid peroxidase and anti-thyroglobulin. So these are auto-antibodies against thyroid antigens. No? So they are present in more than 95% of patients with autoimmune hypothyroidism. So this was asked in the March 2021 PLE. So please familiarize yourselves with these two antibodies in hypothyroidism and thyroid receptor autoantibody in hyperthyroidism. Some patients will present with elevated cholesterol and triglycerides as well as anemia because of decreased lipid turnover and decreased metabolism. Again, a normal TSH excludes primary causes of thyroid dysfunction. And FT4 is inferior to TSH as a screening test because this is the most sensitive test for thyroid dysfunction. Now, how do you check your TSH? Your target TSH for hypothyroidism should be to normalize TSH, and usually we check this every 3 to 4 months kasi nga medyo matagal siya mag-normalize. Matagal siya bago nagiging normal. So it takes a while. So wag kayo mag-check agad, no? Like 2 weeks or 3 weeks after hormone replacement, mag-check na agad. Usually 3 to 4 months before it gets normalized. Now, your thyroid hormones will also cause some form of hyperlipidemia and glucose intolerance kasi nga it reduces the use of glucose and free fatty acids in the circulation. How do we treat hypothyroidism? Very straightforward. We give thyroid hormone replacement in the form of levothyroxine. So levothyroxine is actually T4 at a dose of 1.6 microgram per kilogram per day, 30 to 60 minutes before breakfast with water only. So if you have a 60-kilogram patient, usually that patient requires around 100 microgram per day. So what is the reason why we give it 30 to 60 minutes before breakfast and water only? Because many medications, including calcium, ferrous sulfate, even milk tea, or coffee, would interfere with its absorption, leading to lower efficacy. Dose of levothyroxine should be increased by 30% in pregnancy starting the first trimester. So this is because of the increase in thyroid binding globulins in pregnancy. So kailangan mong taasan yung thyroid hormones niya. So madali tandaan, kung nagbibigay ka ng 100 micrograms every day to a patient, to a non-pregnant patient, so that's Monday to Sunday, so 7 tablets. Usually for pregnant, we give 9 tablets. Nagdadagdag kami ng Saturday and Sunday, tig isa-isa. So that's the easier way of remembering it when you're in clinical practice. Now, certain patients also need dose reduction because of the adverse effects of levothyroxine of increasing heart rate and also adverse effects to the bone by decreasing bone density. So usually, dose reduction is recommended for patients who are elderly and those with cardiac disease, no? Previous history of MI, heart failure, or may na-cabbage. And this was emphasized earlier. So usually avoid concomitant administration of levothyroxine with food, ferrosulfate, calcium-containing medications, your proton pump inhibitors, because proton pump inhibitors decrease acidity of the stomach, decreasing absorption of levothyroxine, as well as aluminum hydroxide and sucralfate, which decreases its absorption. So kung hindi kaya ng patient na i-take siya before breakfast with water only, we usually recommend them to take it 3 to 4 hours after dinner or immediately before bedtime. Pwede din naman yun. So remember, actually itong question daw was asked in the previous 2 PLEs of March 2023 and October 2022. They asked about drug interactions of levothyroxine, and then what can you do if the patient is on your proton pump inhibitors? So may mga questions na ganun. And what clinical situations do you have to decrease the dose of levothyroxine? So very short slide, very short part in the handout and in Harrison's, but very important. Kasi nga, this is commonly encountered in clinical practice and also a very common condition. No? Now, for thyroid, the last part would deal with thyroid nodules and thyroid cancer. So a 40-year-old woman presents their clinic for annual checkup. She denies any medical problems. On physical exam, there is a discrete, firm, non-tender nodule, approximately 1 centimeter. It's palpable and lateral to the midline of the neck and rises when the patient swallows. So what is the most likely diagnosis? The size is 1 centimeter. So this is a thyroid nodule. What is the size of a nodule to be able to be detected on palpation during physical exam? So the cutoff should be more than 1 centimeter in diameter. So what is the next best step? So get a TSH because the nodule could be hyper-functioning or non-functioning. What is the next best step in evaluation if TSH is low? So if TSH is low, it means that TSH is suppressed by high T4 or T3. So the correct answer is to do a thyroid scan to check if there is high radiation uptake of the nodule. What is the next step in the evaluation if the TSH is high? Ultrasound-guided fine needle aspiration biopsy. So we do FNAB, especially if TSH is high, because you want to rule out malignancy. What is the greatest concern for a patient with this condition? So obviously, it's the risk of malignancy or the development of thyroid cancer. So clinical features of thyroid nodules, the greatest concern in a patient with a thyroid nodule is whether it's malignant or benign. So again, most palpable nodules are usually more than 1 centimeter in diameter. And thyroid function should be assessed by measuring TSH levels. So again, important because TSH is the most sensitive indicator of thyroid dysfunction. Thyroid scan or a radioactive scan is indicated if TSH is suppressed because you want to see if the nodule is hyperfunctioning. So kung hyperfunctioning kasi yung nodule, ang tawag dun toxic adenoma. O, iba ang management ng toxic adenoma versus a non-functioning nodule. Now, if TSH is not suppressed, usually request for an ultrasound-guided FNAB. So this is a very useful algorithm for the management of thyroid nodules. So if you suspect a thyroid nodule with normal TSH or elevated TSH, so you do a neck ultrasonography. So if the patient has high suspicion or intermediate suspicion for cancer, you do FNA if it's more than or equal to 1 centimeter. If it's a low suspicion pattern, you do it at more than or equal to 1.5 centimeters. And very low suspicion, you do FNA at more than or equal to 2 centimeters. If the patient has a benign pattern, usually hindi kami nagre-require ng FNA. So ano yung mga benign pattern? So titignan natin later on. Or yung mga cystic. Now, if you do FNA, depending on the size cutoff and suspicious patterns, you classify it according to Bethesda system. So it could be non-diagnostic, ibig sabihin ulitin FNA. If it's benign, no surgery is needed. If it's AUS or atypia of unknown significance or follicular lesion of unknown significance plus follicular neoplasia or follicular neoplasm, look at recommendations. Now, suspicious for malignancy or malignancy recommends surgery. So what are the high suspicion patterns? Ibig sabihin ng high suspicion patterns, you have a 70 to 90% risk of malignancy. So please remember these features. Microcalcifications, hypoechoic with irregular margins, taller than wide, extrathyroidal extension, interrupted rim calcifications, and your suspicious lateral lymphadenopathies or the presence of suspicious looking lymph nodes. Intermediate suspicion will have a lesser chance of being malignant at 10 to 20%. So these are the hypoechoic solid, but with regular margins, or hypoechoic solid masses. Now, low suspicion will have 5 to 10% risk of being malignant. So ito na yung mga hyperechoic, isoechoic, partially cystic, with eccentric solid areas. But how about very low suspicion? Ito yung spongiform, partially cystic, no suspicious features, and benign is cystic. Now, after you biopsy the nodule, the next step is to classify it according to the Bethesda grading for cytology. So after the biopsy of nodules using FNA, ultrasound-guided FNA, so usually the pathologist will grade the cytology based on the Bethesda grading. So this comprises categories 1 to 5. So actually, there's already an update. So this is the older Bethesda classification, but there's already a 2023 update. But it just came out this month, so I doubt that that will be the one to be used in the exam, but we will need to update this for the subsequent batches. But Bethesda is subdivided into 6 categories, so it's numbered 1 to 6. So number 1 is non-diagnostic or unsatisfactory, followed by benign, atypia of undetermined significance, follicular lesion of undetermined significance, follicular neoplasm or suspicious for follicular neoplasm, suspicious for malignancy, and lastly, malignant. So you can see that in the category, as you go down, the risk or predicted risk of malignancy increases. So please be able to familiarize yourself with the numbers, no? Kasi minsan tinatanong nila specific yan yung numbers talaga, kung anong risk. Now, after, for instance, your patient has either suspicious for malignancy or malignant, this leads us to thyroid cancer. No? So thyroid cancer is the most common malignancy of the endocrine system. So most of the tumors are well-differentiated tumors. So it comprises papillary thyroid cancer and follicular thyroid cancer. So thyroid cancer is relatively benign in terms of prognosis because it's curable and prognosis is good for those at early stage. But there are other forms of cancer that have poorer prognosis, no? So medullary thyroid cancer is from the thyroid C cells, which secrete calcitonin and could be part of the multiple endocrine neoplasia syndrome. So MEN2A and MEN2B. Now, you have the very poorly differentiated thyroid tumors. These are anaplastic thyroid cancers. So, anaplastic thyroid cancers are aggressive, they respond poorly to treatment, and is associated with a bleak prognosis. So, ito yung pinakapangit amongst the thyroid cancers. All right, so now we're done with thyroid disorders. We now go to the less common endocrine conditions, but still prudent to discuss because they might still be asked in your upcoming exam. So the first would be Cushing syndrome. So Cushing syndrome, before we start, let's just review some clinical pearls. So when you have pituitary compression or destruction, usually the hormones are lost sequentially. So nauuna si growth hormone, followed by FSH, LH, TSH, and ACTH. So para matandaan nyo to, ang unang nawawala yung less essential. So growth hormones for growth, unang mawawala, followed by reproduction, and then metabolism, and lastly is ACTH. Kasi pinaka-important sa apat ACTH because cortisol is actually essential for life. And therefore, during childhood, the most often presenting feature of pituitary disease is often growth retardation. But in adults, it's hypogonadism. Kasi nga, you already reach adult height. So usually don't see manifestations of growth hormone deficiency. Usually non-specific yun eh. Usually weakness, tiredness. Remember, your pituitary gland responds to hypothalamic releasing hormones. So pituitary glands secrete TSH. We've discussed this earlier in thyroid to stimulate thyroid gland to secrete thyroid hormones. And then you have prolactin, which is responsible for breast milk secretion and contraction of myoepithelial cells. Now, your prolactin is different because it is inhibited by dopamine. ACTH stimulates adrenal cortex, particularly the zona fasciculata, to secrete cortisol. And then FSH, LH act on the gonads and ovary testes respectively. Growth hormone acts on several different systems to stimulate growth, and it is inhibited by somatostatin. So here we have a case of a 30-year-old woman complaining of thinning of the skin, excessive hair growth, and weight gain. She is on chronic oral prednisone for treatment of bronchial asthma. On examination, her face is round and flushed, and there is central obesity with wide purple striae on abdominal area. So what is the most likely diagnosis? So this is to consider Cushing syndrome. What are considered specific clinical features in patients with Cushing syndrome? So we have fragility of the skin, easy bruisability, and broad, greater than 1 centimeter purplish striae and signs of proximal myopathy. So please remember the specific clinical features or features with high discriminative index to say that this is Cushing's. So what is the best initial diagnostic test? So 1 milligram overnight dexamethasone suppression test or 24-hour urine cortisol. So in endocrinology, the dictum is very simple. In hormone deficiency, you do stimulation test. In hormone excess, you do suppression test. Kasi nga, ang normal is, dapat, pag nagbigay ka ng steroid, dapat nasusuppress ang secretion. It means normal feedback is there. But if it doesn't suppress, then there's loss of normal feedback. May excess ka. Then ngayon naman, for stimulation, kung kulang ka ng hormones, you do stimulation test. Because kung kulang, dapat ang normal is walang negative feedback. It would stimulate more secretion. But kung hindi yun nangyayari, it means you have hormone deficiency. What is the next best step if the patient has hypercortisolism? You check the plasma ACTH. Question: what is the most common cause of Cushing syndrome? So the correct answer for this question is letter A, exogenous steroids. Because if you take excess steroids, it would suppress your pituitary ACTH. So that would lead to excess negative feedback. So you don't have ACTH that would stimulate the adrenal cortex. So ngayon, pag natigil mo yung exogenous steroids, you will get Cushing syndrome from the excess steroids. At the same time, hindi makapag-cope yung system. So the term Cushing's disease and Cushing syndrome are different, no? So Cushing's disease refers specifically to Cushing syndrome caused by a pituitary adenoma. Ibig sabihin, ACTH secreting pituitary adenoma. That's Cushing's disease. Now, Cushing syndrome pertains to any cause of Cushing's syndrome, including exogenous steroids and the other causes. So at least 90% of patients with Cushing's disease, the ACTH is caused by pituitary adenoma, only a few millimeters. Maliit lang. So it's a microadenoma. So, but overall, worldwide, the medical use of corticosteroids for immunosuppression or treatment of inflammatory conditions is the most common cause of Cushing syndrome. So what's the working algorithm? Clinical suspicion of Cushing's with these features: central adiposity, proximal myopathy, striae, amenorrhea, hirsutism, impaired glucose tolerance, diastolic hypertension, and osteoporosis would lead to your screening and confirmatory testing. So how do you screen? You can check for 24-hour urine-free cortisol, which is 3 times elevated upper limit of normal. You can do dexamethasone suppression test. Kung ibig sabihin ng unsuppressed, the plasma cortisol is more than 50 nanomoles per liter at morning. And also a midnight plasma cortisol or a midnight salivary cortisol that is elevated. So ano bang rationale behind this? So remember your circadian rhythm. Your cortisol rises at 8 to 9 a.m. and it goes down at night and achieves a nadir at around midnight. So kung 24-hour urine-free cortisol mo, mataas siya, ibig sabihin it's excess over the 24-hour period. Ngayon, yung midnight, diba sabi natin, the lowest point of cortisol secretion in the body is midnight. So pag mataas ang midnight cortisol mo, both in the plasma and the saliva, ibig sabihin there's loss of circadian rhythm. So ibig sabihin mataas yung cortisol mo talaga. Now, what are the clinical features of Cushing syndrome? So again, it's a constellation of clinical features from abnormally elevated steroids, whether exogenous or overproduction of cortisol by the adenoma, leading to these features. No, these are from the actions of cortisol on the glucocorticoid receptor. You get weight gain, central obesity, moon fascies, fat pads on the neck and back. We call it buffalo hump, hirsutism. Your very broad, more than 1 centimeter purple stretch marks or striae, muscle weakness and atrophy, hypertension, edema, decreased libido, amenorrhea, irritability, and depression. So Cushing syndrome, again, is from excess cortisol of any cause, but Cushing's disease is excess cortisol from an ACTH-producing pituitary microadenoma. So amenorrhea can actually be caused by Cushing syndrome because cortisol can inhibit gonadotropin release in the pituitary gland. So pwede ka mag-amenorrhea. And cortisol is also involved in increased gluconeogenesis. Kaya pwede ka magkaroon ng impaired glucose tolerance, di ba? At the same time, cortisol breaks down bone, skin protein to make sugar. So this leads to the striae, the bruising, and the wasting, and also some form of osteoporosis. Now, what are the summary to the different diagnostic tests? So isa-isahin natin. So you have adrenal Cushing syndrome. So cortisol is increased, but ACTH is decreased. Kasi nga, na-inhibit ng cortisol from the adrenals yung ACTH by negative feedback. So high-dose dexamethasone suppression test has no effect. So it doesn't suppress because the defect is in the adrenal gland. CRH stimulation, no response because it's not, the lesion is not in the pituitary gland. Now, pituitary Cushing syndrome, this is Cushing's disease. Again, it also has increased cortisol levels, but ACTH is increased because the lesion is in the pituitary, so nag-i-increase yung synthesis of your ACTH. Now, since the lesion is in the pituitary, it retains some suppression to high-dose dexamethasone suppression. So, nasusuppress siya. And since the lesion is in the pituitary, if you give CRH from the hypothalamus, it will respond. It will increase your secretion. Now, ectopic Cushing syndrome is ACTH production elsewhere outside the pituitary gland and adrenal gland. So usually this is from bronchial carcinoid, no, or GI carcinoid. So again, increased cortisol, increased ACTH, but it's not from the pituitary, it's elsewhere. But since it's not from the pituitary, it won't respond to high-dose dexamethasone, and at the same time, it won't respond to CRH kasi iba nga yung itsura ng receptors niya. It doesn't have receptors that would respond to DEXA and CRH. So how do you distinguish the three? Syempre, you cannot use cortisol. So it's all increased. So for ACTH, you can look at for adrenal, it's decreased because of the excess negative feedback from cortisol secretion in adrenals. For the two, it's increased. Now for high-dose DST, only Cushing's disease will be suppressed and the rest will have no effect, and only Cushing's disease will have a response to CRH stimulation. So madali siyang tandaan. Now again, recall this diagram. So CRH from hypothalamus will stimulate the anterior pituitary to secrete ACTH, and ACTH will act on the adrenal cortex to secrete cortisol. And cortisol will exert negative feedback on both the pituitary gland and the hypothalamus. So kung galing sa adrenal ang cortisol, it will suppress ACTH and CRH. That's why decrease ang ACTH. But kung dito galing kasi sa pituitary yung ACTH mo, it will stimulate the adrenal cortex. Kaya mataas parehas, no? Mataas ang ACTH and cortisol. Again, basal plasma ACTH will help you distinguish between ACTH independent, so that is adrenal and exogenous glucocorticoid, from ACTH dependent. Ibig sabihin, nagsisecrete ng ACTH. So, dalawa lang naman yun. Pituitary or the Cushing's disease and ectopic ACTH secretion. And how to distinguish between Cushing's disease and ectopic ACTH is just from this table, no? Response to high-dose dexamethasone suppression test and also the CRH stimulation test. Now, again, a review of the diagnostic test. Overnight DST, you give 1 milligram dexamethasone at 11 and you check the cortisol at 11. A normal response means it has to be less than 50 nanomoles per liter. 24-hour urine test will check 24-hour overall levels if the overnight dexamethasone suppression is not falsely abnormal. ACTH will help you determine if it's ACTH dependent or not, and they help locate the source of the hypercortisolism. CRH test, again, similar to the table I've shown earlier, it helps you distinguish pituitary Cushing's versus ectopic ACTH. And of course, imaging studies as indicated. Depende kung nasan yung lesion. So this is just an algorithm. Earlier, I've showed you the clinical suspicion and screening test. Now, kung nag-positive siya dito, the next step is to screen using plasma ACTH. If the ACTH is high, ibig sabihin it's more than 15 picograms per ml. So it's ACTH dependent Cushing. So either ectopic ACTH secretion or pituitary Cushing's. So you can do an MRI. You can do a CRH test and a high-dose dexamethasone suppression test. So pag na-suppress dito sa high-dose dexa na stimulate ng CRH, may lesion sa MRI, then it's Cushing's disease. The treatment is transsphenoidal surgery. Now, if it's both are negative, then it's likely ectopic ACTH production. So usually, if it's ectopic ACTH, we usually locate and remove the source of ACTH. So you do a chest and abdominal CT scan. Kasi usually carcinoid yung tumors eh. So dun mo siya hahanapin. Now, if you get equivocal results with these, you do an inferior petrosal sinus sampling. So you get the ratio of ACTH in the inferior petrosal sinus versus peripheral blood. So it's if the ratio is more than 2 or more than 3 after CRH, then you would be able to determine it's in the pituitary. Now, kung mababa ang ACTH mo, ibig sabihin, wala sa pituitary yung lesion at saka hindi siya ACTH dependent. So, you check CT scan of the adrenals. If it's a unilateral adrenal mass, you do work up for the tumor. So, ibig sabihin, you work up for your cortisol-secreting adenoma, pwedeng primary hyperaldosteronism, and roll out pheochromocytoma. Usually, surgery yon pag unilateral. Pag bilateral ang lesion mo, kung hindi kaya ng medical therapy, you do bilateral adrenalectomy. So, next question is, what levels of ACTH do you expect to see in patients with ectopic ACTH secretion from a small cell lung cancer? So, the correct answer is very high. So, syempre, hindi na siya undetectable below kasi ectopic ACTH secretion na nga. So, ang sagot na lang B or C. But usually, B is limited for patients with Cushing's disease. Very important table from Harrison's, how to distinguish an ACTH secreting pituitary tumor or Cushing's disease versus ectopic ACTH secretion. So, again, etiology, ACTH2 pituitary adenoma is corticotroph adenoma versus ectopic secretion is usually bronchial abdominal carcinoid and small cell lung cancer as well as thymoma. Sex predilection, Cushing's disease, more female. Ectopic is more male. Clinical features, mas mabilis ang onset sa ACTH, ectopic ACTH kasi nga very high levels of ACTH as we pointed out earlier. So you get rapid onset pigmentation, severe myopathy, and potassium is usually less than potassium of less than 3.3 or hypokalemia is more common in ectopic ACTH secretion kasi yung sobrang ACTH would stimulate cortisol production, and that cortisol production also binds to mineralocorticoid receptor. So basal ACTH, very high sa ectopic. And then microadenomas account for 90% of ACTH producing tumors. Macro is only 50%. And remember, for dexamethasone suppression, for low dose, both unsuppressed, but for high dose, Cushing's disease would be suppressed. And for inferior petrosal sinus sampling, elevated ang ratios ng Cushing's disease. Kasi nga, syempre, mas mataas yung ACTH dun sa inferior petrosal sinus versus periphery. Whereas for ectopic ACTH, peripheral lang mataas. Again, a serum cortisol of more than 5, a patient has Cushing syndrome. Low ACTH meaning nasusuppress ang ACTH. And also, from negative feedback, that's adrenal cause. High ACTH, pituitary Cushing's or ectopic production. Suppression with high dose DEXA, ACTH, pituitary origin. High dose DST does not suppress ACTH, ectopic production, likely cancer ang cause natin. So how do you treat Cushing syndrome? If it's Cushing's disease, meaning the lesion is in the pituitary gland, the treatment of choice is selective removal of your pituitary adenoma, usually via an endoscopic transsphenoidal approach. If it's ACTH independent, so usually you remove the adrenal tumor. So majority of ACTH independent are from a cortisol producing adrenal adenoma. So it's unilateral adrenalectomy. So there are some oral agents with established efficacy in Cushing syndrome, such as metarapone and ketoconazole. But usually we don't routinely give these medications unless sobrang uncontrolled na or a poor candidate for surgery. So mitotane, a derivative of the insecticide DTT, is an adrenolytic agent, is also effective for reducing cortisol, but this is more commonly used for adrenocortical carcinoma.
So metyrapone inhibits cortisol synthesis at the level of 11 beta hydroxylase, and ketoconazole will inhibit earlier steps of steroidogenesis, usually the P450 enzymes. Now, metyrapone is the only adrenal inhibiting medication that is approved for pregnancy in patients with Cushing syndrome. So, baka lang itanong ito. All right, so we're down to the last few conditions for general endocrinology. So, first, we'll discuss secondary hypertension. So, the most common would be primary hyperaldosteronism. So, let's look at this case. A 32-year-old male presents with lower extremity weakness. Blood pressure was 180 to 90 over 90 to 100 in all extremities. The serum potassium was 2.1. Other laboratory workups were non-contributory. So what are your possible differentials? So you have a patient with hypertension. So hypertension in the young, likely secondary hypertension. So you check for hyperaldosteronism, especially in a patient with hypokalemia. And then hyperthyroidism pwede kasi may thyrotoxic periodic paralysis which we discussed earlier, right? So yung may mababa ang potassium. And then last is pheochromocytoma. So the pathophysiology of hyperaldosteronism results from excess aldosterone secretion from the zona glomerulosa of the adrenal cortex. So it could be due to an aldosterone-producing adenoma or your APA, and your bilateral idiopathic hyperplasia or your IHA. So that's the bilateral disease. So clinical hallmark of primary aldosteronism is hypertensive with unprovoked or diuretic-induced hypokalemia. So the first-line treatment remains to be surgery for unilateral masses and medical treatment for bilateral disease or those with contraindications to surgery. So what are the drugs of choice? So it's spironolactone or eplerenone, which are selective mineralocorticoid antagonists. So they would block the actions of aldosterone on the aldosterone receptor, preventing the vasoconstriction, hypertension, as well as potassium secretion. Kaya nga, di ba, ang side effect ng spironolactone eplerenone is hyperkalemia. How about pheochromocytoma? Pheochromocytoma is characterized by the classic triad of profuse sweating, headaches, and episodic palpitations. And the dominant sign is hypertension. So ang ano dito is episodic lang palpitations niya. Kumbaga meron siyang episodes only because hormone release is periodic as well. So episodes of hormone release, the patients become anxious and pale with tachycardia palpitations. And these are called paroxysms. They usually last less than 1 hour, and they can be precipitated by surgery, positional changes, exercise, pregnancy, even urination, especially if the pheochromocytoma is inside the bladder. And various other medications, usually tricyclic antidepressants, opioids, and metoclopramide. This is a very common question in which pheochromocytoma is associated with the rules of 10, 10% bilateral, 10% extraadrenal, and 10% malignant. So how do you diagnose and treat pheochromocytoma? So the most sensitive and least susceptible to false positive elevations from stress would include measurements of plasma metanephrines. Metanephrines are metabolites of norepinephrine and epinephrine, which are secreted by your pheochromocytoma. Pharmacologic treatment involves alpha blockade. Usually it requires 7 days. So what are your alpha blockers? So that's your terasocin, prazosin, fusosin, tamsulosin, tama. So before surgery, blood pressure should be controlled first and should be consistently less than 160 over 90 millimeters mercury. And this is based on Roizen criteria. Now, after sufficient alpha blockade, you give beta blockade as needed for the tachycardia. Now, once you localize the tumor on CT scan, you can do laparotomy, which is the traditional surgical approach. And then now the method of choice is a traumatic endoscopic surgery or even robotic and minimally invasive surgery. Some clinical pearls, some conditions are associated with pheochromocytoma. So this is neurofibromatosis type 1 or NF1. And then again, your NF1 presents with multiple neurofibromas, your cafe au lait spots, axillary freckling, leash nodules of the iris. It's also associated with MEN1, which is Wermer syndrome, or the 3Ps, pituitary, parathyroid, pancreatic. MEN2A, also known as Sepal syndrome, is associated with medullary thyroid cancer, which is the most common one virtually seen in all patients. 50% will have pheochromocytoma, usually bilateral, and hyperparathyroidism. And you also have MEN2B, and this is also manifesting with medullary thyroid cancer, pheochromocytoma. Kaya lang walang hyperpara sa MEN2B. It's usually multiple mucosal neuromas, a marfanoid habitus. So usually patients with pheochromocytomas, pag associated siya with syndromes or genetic conditions, usually it's bilateral. And now lastly, we proceed to osteoporosis. So ito important, no? Kasi we have an aging population. So it's also important to know how to diagnose and treat osteoporosis. So we have a case of a 70-year-old woman presenting with low back pain. There's no history of trauma. And this patient had menopause at age 48. On lumbar spine x-ray, there is vertebral fracture at L4 and notable osteopenic changes. So what is the most likely diagnosis? So this is, you have a vertebral fracture at level 4, L4, and osteopenic changes. Despite the fact it's osteopenic, you already have a fracture. So that's osteoporosis. What is the operational definition of this condition? So we base our diagnosis on bone mineral density of less than 2.5 standard deviations from normal peak bone mass, or a T-score of less than negative 2.5. What are the risk factors identified in our patient? So patient is menopausal and also elderly, increasing age. So clinical features, it's decreased bone strength associated with bone mineralization due to withdrawal of estrogen. So risk factors include postmenopausal women, increasing age, and those with family history, smoking, low body weight, excessive alcohol intake, those with prior fractures, steroid use, hypogonadism in men, inadequate physical activity, and immobilization. So yung mga nabalian, nakakas, no, matagal naka-immobilize, are at risk to develop osteoporosis. Usually it's asymptomatic, but acute to chronic back pain may actually be to subtle fractures, like for the case of our patient. Chief clinical manifestations are hip and vertebral fractures. How to diagnose? It's usually diagnosed by dual energy X-ray absorptiometry, or the DEXA scan. Osteoporosis means the cutoff or the T-score is negative 2.5. Osteopenia is T-score between negative 1 to negative 2.5 standard deviations. And usually check for serum levels of calcium, phosphorus, alkaline phosphatase, but they're usually normal. So why T-score versus Z-score? I'm sure you've heard of T-score versus Z-score. So T-score compares an individual's results to those in young population that is matched for race and sex. So ito, ang T-score, kino-compare sa young individuals. That's why it's used to diagnose postmenopausal osteoporosis, or those with medyo elderly, even for males. Now, Z-scores compare individual results to your age-matched population. So, mga ka-age group. So, this is for secondary osteoporosis. Ibig sabihin, it's not caused by age or postmenopausal conditions, but more on other medical conditions that could cause osteoporosis. For instance, glucocorticoid use, hypogonadism, or your TV of the bones, no? So Z, same age, para madaling tandaan. So how do you treat osteoporosis? Usually we aim for calcium supplementation. For adults 19 to 50, it's 1,000 milligrams per day. So this is based on Institute of Medicine cutoffs, also endorsed by WHO. Now for adults more than 50, we're endorsing a dose of 1,200 milligrams per day, and vitamin D supplementation of around 1,000 to 2,000 international units per day. We also recommend muscle strengthening, smoking cessation, and avoidance of high excessive alcohol intake. So there are a number of anti-resorptive agents, recall their pharmacology, that could decrease bone resorption in patients with osteoporosis. So that includes raloxifene, your bisphosphonates, alendronate, bisendronate, calcitonin, and denosumab. And you also have anabolic agents that help build the bone mineral density that includes teriparatide, an analog of parathyroid hormone, and romosozumab, an anti-sclerostin inhibitor. All right, so with that, we end the endocrinology part of our lecture. So for endocrinology, which is part of internal medicine and likely also be part of other modules and exams like preventive medicine and also pharmacology and physiology. So I think it's very important to remember your type 2 diabetes. So walang pala yan sa most common, one of the most common conditions in endocrinology. So it's probably going to be asked across different disciplines. And the questions will range from basic science to clinical science, no? So thyroid, the same. Also a lot of physiology, pharmacology, and also clinical disease and treatment. Now, for general endocrinology conditions, since they're relatively rarer compared to diabetes and hyperthyroidism, I would suggest to focus on the physiology, pharmacology of these conditions. And for treatment, you don't need to know the very specific treatment because these are subspec level management. So they usually are handled by subspecialists. So what is important is to know the pathognomonic clinical features and also at least have an idea of how to screen or the gold standard and hallmark features, gold standard for diagnosis and the treatment of choice or the first line treatment. So you don't need that to really know the very specific treatment, but at least know what's first line and what is the most common modality used. For instance, no, yung sa pheochromocytoma, surgical. At least alam mong surgical. Kasi minsan gano'n naman yung choices. Surgical, medical, radiation therapy, observation. Parang gano'n lang siya. Alright, so it's the endocrinology part is actually easy to understand and easy to learn because I'm sure you've seen most of these patients in your rotations, clinical rotations. And it's also important to learn these because later on you will manage these patients in your residency or moonlighting. No? So with that, I wish everyone luck for the upcoming October 2023 physician licensure exam. And if you have questions or queries, please course them through your MGs and they will forward it to us. If you have questions on the lecture and also the handouts, no, please just relay the questions to your MGs. And we hope to see you on the other side. Thank you.